Welcome! The title of our talk is Perils of Data-Driven Equity, Confronting the Fundamental Conditions of Gender and Sexual Minority Health Inequities. Recent years have witnessed a groundswell of interest in the health and healthcare needs of gender and sexual minority people. Growing efforts from advocacy and policy audiences seek to incorporate issues of sexual orientation and gender identity into matters of health and medicine, provoking new institutional activity towards recognizing and redressing LGBTQ+ health disparities. One prime example of this is the expansion of data collection on sexual orientation and gender identity within clinical settings. Advocates and public officials have called for expanded SOGI data collection within electronic health records as a rare opportunity for system transformation. This data collection is expected to thoroughly integrate issues of gender and sexuality within clinical care itself, as conveyed through the primary care encounter on the left, and facilitated through the technical capacity to record such data within EHRs, as shown on the right. Recommended standardized items on SOGI data collection include one item for sexual identity. Do you consider yourself as straight or heterosexual, lesbian, gay, or homosexual, bisexual, something else, don't know, or choosing not to disclose? One item for gender identity, and one item for assigned sex at birth. Taken together, the introduction of these three SOGI items are expected to transform clinical care practices while facilitating population-based research to assess the health and healthcare needs of gender and sexual minorities. Advocates and public officials thus view SOGI data collection in EHRs as the key to ending LGBT health disparities, with data serving as the foundation for understanding the population status and needs while ending LGBT invisibility in healthcare. Such data collection is typically seen as one of the most important things our government has done to promote better understanding of LGBT health disparities and interventions to reduce them. Several federal and state programs have since implemented SOGI data collection as a part of program requirements, oftentimes in the name of disparity reduction. So, taken together, these expectations of transformation, combined with public policy initiatives, have generated a seemingly powerful strategy of data-driven equity, in which data serve as the primary means of advancing social change and redressing inequality. Despite the grand hopes and expectations placed onto data as a strategy for equity, there is little evidence supporting technology-driven point-of-care interventions as means of reducing inequality. Existing studies focus on health IT requirements and implementation, reporting general levels of patient acceptability of SOGI items. But as promising as these studies may appear, they typically employ survey methods that miss crucial elements affecting healthcare delivery and everyday practice. The narrow focus on testing and developing standardized items tells us little about how these standards themselves interact with the social world, which is by no means guaranteed by their design or acceptability, risking limited change to clinical care practices. Furthermore, point-of-care interventions risk deflecting attention away from the fundamental drivers of health inequalities, including the social foundation of healthcare treatment inequities. Thus, institutional activity towards recognizing and redressing LGBTQ+ health disparities, as in the present case of SOGI data collection, warrants empirical scrutiny and fully accounting for the social context of health inequality. The focus on my presentation today is to present findings from an examination of SOGI data directly within the field, in which I examine what I call big data in action. Drawing from a larger qualitative project on the rise of big data analytics within U.S. healthcare and theoretical insights from science and technology studies, I take an ethnographic approach to examine one particular health system's integration of SOGI data within primary care. My field site is a large public safety net health system located on the West Coast, primarily serving low-income patients insured through Medicaid and the remaining uninsured. As a part of the database state accountability program, the health system was required to initiate SOGI data collection and reporting within primary care, informing the present case study. I conducted 10 months of observations across various departments, including administration, the Department of Quality, the IT and Analytics Division, and 2 outpatient clinics. These observations were further supplemented with in-depth, semi-structured interviews with primary care providers, complex care nurses, QI coordinators, clinic managers, and administrators. All field notes and interview data were transcribed and analyzed following the principles of grounded theory and situational analysis. Drawing from this fieldwork, today I will highlight 3 central challenges that elude data's grasp on the problem of inequity. 1. Provider and staff's limited understanding of the social significance of SOGI data. 2. Patient perception of the cultural insensitivity of SOGI items. And 3. Clinic need to balance competing priorities with SOGI collection. So I'll examine each of these 3 themes in turn now. Advocates and public officials typically expect data to stand on their own and yielding self-explanatory information, with SOGI data collection directly leading to providers understanding patients and providing affirmative care. But technical standards alone cannot guarantee that those expected to work with data on the ground share the same understanding as those mandating its collection at the level of policy. Standardized data collection does not tell providers and staff why and how sexual difference matters for health, including its social significance in relation to inequality. One of the main staff members involved with the SOGI initiative identified this as the primary challenge of initiating data collection. With the SOGI questions, I've been given feedback from providers. I don't understand why we're asking these questions. What does this have to do with somebody's health? I understand where they're coming from, there's a lot required of them, and now we're asking them to see providing health in a different way. It's often hard for somebody to even understand why we need to ask these questions, and then having to explain social determinants of health and health disparities to somebody who might not necessarily know what those things are. Even though they work in the health field, but my background is in public health, and there we have a lot of focus on social determinants and stigma. Primary care, from my observation, it doesn't seem like it so much. So it's hard for them to even just understand the concept of health disparities. And if they're not seeing the value of why we need to ask, it's challenging to get their buy-in. Personally, I think we need to do more around social determinants of health and health disparities and really explaining that to people. Because I don't know that everybody's universally on board with why these questions have anything to do with your medical health. So the main challenge here is not in the technical details of health IT requirements, but in communicating how and why sexual difference matters for care and equity. Data alone do not stand in for an argument of the social basis of inequality, such as how sexual orientation and gender identity are linked to social determinants of health and health disparities, nor do they guarantee that such an argument is universally understood among healthcare workers. As frontline providers, analytics staff, and administrators in this safety net institution confront mandated SOGI data collection, as displayed here on screen, technical requirements alone do not convey this social significance of sexual and gender difference, resulting in a decontextualized understanding of gender and sexuality. Without this shared understanding of SOGI data's significance, data collection itself is unlikely to lead to any form of data-driven equity. Additional issues may arise when data collection does not correspond with the social worlds of those being measured, with providers and staff perceiving that not all patients see gender and sexuality as relevant for receiving care. Social assumptions about who and what patients are like, such as being comfortable discussing gender and sexuality, possessing familiarity with American culture, and speaking English supported by a high school education, all play out at the point of data collection, with workers suggesting SOGI domains may be inappropriate in the clinical context due to patient differences in culture, language, and religiosity. The medical director of the system's main outpatient clinic shared her discomfort around asking SOGI items, not because she believed they were entirely unimportant, but because she perceived them to be culturally insensitive among already marginalized patients in the safety net. Yeah, so I think asking SOGI data, the good thing about that is you don't want to miss screening procedures for patients with gender transition, but, at the same time, I don't know if culturally, in my opinion, we are discriminating more by asking these questions, I think. So I followed up. What do you mean? It means everybody is, according to me, already the same. So asking these data and putting them in a separate category, yeah, we can look for screenings, but for example, elderly couples come here, and if we are not culturally sensitive, we go and ask those questions, and patients get really offended, very angry. So I don't know. I'm not really against it, but I'm not a big cheerleader either. I'm okay to ask those questions and document, but I already take care of them. I already take care of gender and sexual minorities without judgment. And asking these questions, we have to be very careful about who we ask here. So I followed up. Have there been any challenges? Yeah, a husband and wife came to the clinic, for example, an Iranian couple. And I asked the wife, because the wife usually comes in with the husband, right? And I asked her, Biologically, do you think at birth you were female or male? What about now? Are you still male or female? And do you like to have sex with men? You know, Iranian culture, even Pakistan, and some Muslims from India, they can be very conservative. So when you ask that question in front of the husband, they both just completely shut down, especially at the beginning of the visit. So for me, then it's kind of difficult because you go in and they're still really upset with those questions. Why are you asking me this? Are they going to ask me these questions every single visit? If they don't have such questions in the future, I would really appreciate it. I think it's a taboo for them talking about sex. I think it's the culture, completely cultural. So in this instance, this medical director draws from her own experience as an immigrant from India herself, as well as a provider in the safety net context, to explain patient reactions to SOGI items. The perceived benefit of asking all patients the SOGI items, assumed within the strategy of mandated data collection, was rarely viewed as outweighing the risk of alienating already marginalized patients, a particularly sensitive issue within this safety net context. Providers and staff further find themselves poorly equipped to translate these standardized items across class, culture, language, and religion, with healthcare workers unable to do the behind-the-scenes contextual work rarely acknowledged by advocates of data-driven equity. SOGI data are merely one of many items collected, including health behavior assessments, substance use screenings, physical abuse questionnaires, and patient satisfaction surveys. In isolation, each of these data points are arguably introduced for optimizing patient health. Taken together, however, they crowd each other out given the particular context of safety net care and shortened 15-minute appointment visits. From the one-time asking of SOGI items, advocates and public officials expect providers to provide competent, affirmative care based on resulting data. But this is unlikely to happen if providers do not have the time and resources to consult with such data as a part of their regular work. One physician champion noted the strong impact her working conditions has on her ability to engage with SOGI data. So I asked, how do you think providers would react to having the SOGI data available in the EHR, in the electronic health record? I think they're too busy to pay attention, honestly. I mean, it might make a difference in terms of screening people for sexually transmitted diseases or that kind of thing, but, to be honest, I'm not sure it really makes a big difference with everything else that we already have going on here. So she elaborated. Data's great, but you have to have the time and energy to be able to look at it and understand what it means. And for us right now, it's really all about visits. My docs were seeing patients 9 half-days a week. That 4 extra hours is filled with disability forms, medication refills. You're working all the time, and you don't have a block where you can just sit down and go, oh, look, let's pull up the data from this population or that population. 11 patients per half day is a lot of patients, and the more patients you see, the more lab results you have, more refills you have, more work there is to be done on the in-basket. For a working doc here, we just don't have time. Asking patients about their sexual orientation and gender identity in this particular context is quickly considered to be just one more thing in comparison with what is deemed to be much more important for care. This is not to say that SOGI data have no value whatsoever. Rather, it has relatively little value in this provider's assessment compared to the many other demands on her time. If there is no time or ability for providers and staff to meaningfully engage with data, then what is the real value of its collection? Data advocates may continue to argue for data-driven equity, but without a full understanding of the organizational context of care, including what care provision is like in the safety net, they risk increasing burden without yielding transformation. So the themes I identify here speak to important contextual elements of health inequality that are unlikely to be redressed through data collection alone. While standardized data may hold great potential in bringing about change, this is neither automatic nor guaranteed, especially when divorced from the social context of both safety net care and health inequality. Furthermore, such point-of-care interventions are likely to remain ineffective insofar as they deflect attention away from the root causes of gender and sexual minority health inequities. While classic sociological understandings of these root causes focus on domains that exist beyond the scope of clinical care, the surge of interest in integrating social determinants such as sexual orientation and gender identity within healthcare and clinical care services suggests a need to re-examine how inequality is ingrained into the institution of medicine itself. In other words, we must focus on the fundamental conditions of health and healthcare inequities, the upstream institutional level factors of medicine itself that shape the quality and character of all downstream patient-provider interactions. Consider the perils of data-driven equity, in which data serve as the primary means of advancing social change, intervening upon clinical settings as potential sites for redressing inequality. Yet this strategy takes place at the expense of redressing the institutional level factors of gender and sexual minority health inequities. The systemic deprioritization of gender and sexual minorities runs deep throughout all of medicine and healthcare. It shapes the content and breadth of clinical training, with limited attention given to gender and sexuality within health professions education, the location and scope of sites of care, with the separation of mainstream care organizations from LGBTQ-oriented clinics, the relative diversity of the health professions workforce, and the current state of biomedical knowledge. Technology-driven interventions focused on transforming medicine at the point of care are simply too weak to counteract the powerful forces of deeply entrenched institutionalized inequity. To redress this inequity, we need to look upstream at the institutional conditions affecting the seemingly evident health and healthcare needs of gender and sexual minorities. To truly advance the highest possible standard of health for all people, we need more than mere downstream data-driven interventions in the name of disparity reduction. We need to confront the social conditions that reflect and shape where and how certain people stand relative to others. In short, we need true institutional transformation, not just focused on assessing how things currently are, but envisioning how they otherwise could be. I'd like to thank my colleagues at UCSF and Cal State, acknowledge my sources of funding. If you are interested at all in learning more about this research, this article is now published in Big Data and Society. Otherwise, feel free to reach out to me via email or Twitter. Thanks so much for your time and attention.